Good morning, everyone. Thank you so much for joining us for this symposium on sexual and reproductive health in CF. We've got a great panel of speakers, and we are really excited to have this conversation today, as it's definitely an important concept for our CF care teams. So we do have a few objectives for the session. We'll be talking about some of the key recommendations from the Cystic Fibrosis Foundation Sexual and Reproductive Health Position Paper draft. We'll talk about some of the unique challenges for people with CF in the sexual and reproductive health space. Particularly, participants will understand what it means for male infertility in CF. We'll talk about current options, including testosterone supplementation, clarify some common myths related to oral contraceptive use, and learn useful strategies for sexual and reproductive health counseling throughout different stages of life. And then finally, we'll be talking about strategies to incorporate sexual and reproductive health into both pediatric and adolescent CF care to make sure we're addressing these topics across the age span. Our first speaker is going to be talking about sexual and reproductive health guidance for the CF community, and I'm so pleased to introduce my co-moderator, Ellen Meyer, who is a pediatric nurse practitioner and CF Center Coordinator in the Pediatric CF program at Children's Mercy, Kansas City. She completed her undergraduate training at the University of Iowa and her master's in nursing and nurse practitioner degree here in Seattle at the University of Washington. She's been working in CF care for 14 years. Throughout her care, she has participated in CFF mentorship opportunities, quality improvement projects, and research to advance the care provided for those with CF. She has received awards for patient experience, clinical practice, and teaching throughout her career. So I'm pleased to introduce Ellen.
Thank you. I'm so excited to be here with all of you today. And to kick off our session, I don't have any relationships to disclose that are related to this talk. And like Kevin mentioned, I'll be touching on information from a draft of the Cystic Fibrosis Foundation's Sexual and Reproductive Health Position Paper. So this has been submitted for publication, but many of you were able to review it, and hopefully some of you submitted public comment in the spring. And so I'll touch on some content from this paper. It's a position paper rather than a guidelines document, and so I just want to point that out and make that clear, that it will provide expert commentary and suggestions and consideration for care team members, and instead of official recommendations from the Cystic Fibrosis Foundation. But as all of us know, this is a really important topic. People with CF, many of them are living longer and healthier lives. We have this lovely graph from the 2024 CF Patient Registry Report that shows us that the median predicted survival is now 65. And as a result of the changes in CF care over the last decades, we know that sexual and reproductive health care education and care delivery is becoming increasingly important. There's been a lot more focus on contraception and pregnancy and fertility in people with CF, but there's still significant misconceptions. So I'll highlight this from the pending publication, and this shows pregnancy rates as reported in the US and UK CF registry. You can see that the blue line represents registry data from the United States. The orange line represents registry data from the UK, and the arrows show the respective approval dates of ETI. And so obviously what this shows us is there have been significant increases in multiple countries that have access to highly effective modulators, and we're seeing a lot more women with CF who are pregnant. So the CF Foundation got together a group of experts, care team members, people with CF to draft a position paper, and a literature review was completed. And the intent was to provide some guidance regarding 5 different domains. And the domains were how to deliver reproductive and sexual health care, fertility, contraception, preconception and pregnancy, and CFTR modulator exposure in utero and during lactation. And as mentioned, that was available for public comment in the spring, and there may be some edits in the final version after the public comment has been taken into consideration. So I'll start and I'll touch on sexual and reproductive health care delivery. This is a really complex process because, as we know, this healthcare can be delivered and is delivered in the primary care setting within the context of CF clinic and then within the context of tertiary and specialty care as well. And we know that there are significant gaps in sexual and reproductive health care. 2 years ago at the plenary session, Tracy Kazmierski did a fabulous job helping us understand the gaps in sexual and reproductive health care in people with CF. But I just wanted to review, because I think every time I see studies like this, it just highlights for me the need for us to continue to move forward and provide this guidance in the CF clinic setting. But we have studies that show us that females with CF report lower rates of contraceptive counseling. One study that showed us that nearly half of pregnancies in females with CF were unplanned. Another that showed us that young women with CF report a similar prevalence of STIs, but lower rates of screening compared to the general population. Another data set showed us that men with CF report suboptimal condom use, with 1/3 of adolescents disclosing their assumption that they didn't need to use condoms. And then we know that women with CF have had lower lifetime rates of ever obtaining a pap smear or a pelvic exam. So sexual and reproductive health care is often delivered in a primary care setting in adolescents and adults. And many people with CF don't have a PCP. And even those with CF that do have a PCP, we know that they really want to discuss these concerns with their care team members. We have data to show us that they would prefer to discuss these issues with their CF care team members. And despite that strong preference, less than 50% report the opportunity to have these conversations with their CF team providers. And we know that people with CF report that they would prefer routine, age-appropriate discussions about topics like contraception and sexual debut, and they'd like for this to start happening in their early adolescent time period. And most adolescents and young adults prefer this to occur privately. And CF providers and teams may not have the expertise or the comfort level or the time in their clinical setting, and so I think this further highlights why we have some gaps in this care. And so when it comes to care delivery, some suggestions for the CF community that are being made is, one, that education should really begin at the time of diagnosis. I think it's important for us to realize that talking about fertility implications is something that should start very early, and that sexual and reproductive health care should be discussed with caregivers throughout childhood. This should be something that's talked about regularly in the pediatric clinic setting. And then one consideration for teams, and I am an advocate for this practice because I've seen it succeed at my CF center, is that CF teams should develop a standardized approach to address these needs within their clinic. And this could include designating a certain care team member as a content expert or certain people on the team and pulling in their strengths and their passions to make sure that this education gets provided to our patients. And then education should really be related to both general and CF-specific concerns, and this is something that should be revisited annually over the course of the lifespan. And then, as stated, confidential counseling should really happen. It's what people with CF tell us that they want, and so hopefully in early adolescence, this would be a consideration for people in their CF clinic settings. It's important when we're talking about this education to remember some core tenets like bodily autonomy, the importance of comprehensive, neutral, inclusive language that's supporting all people with CF and all types of relationships. And then it's important to remember that people with CF pursue a variety of family building paths. So this is a list of topics that could be considered to be discussed in your clinic setting, and they could vary based on age and circumstance, but there's a long list of them. They include pubertal development, fertility, contraception, STI prevention, reproductive and parenthood options, urinary incontinence, immunizations such as HPV, body image, gender identity, sexual functioning, cancer screening, genetic counseling, and preconception planning. So just looking at that list is a little exhausting. I think lots of us don't feel like we are content experts, but I wanted to provide you with some resources that I've personally found really helpful. These are two of my favorite websites regarding this topic. The first is from CF Fresh, and there's wonderful information for patients, clinicians. And then the second is the Center for Young Women's Health. There's a sexual and reproductive guide for teens and young adults. And I have sent this link to numerous patients, printed off information from this website for them. It's really detail-oriented, and it's been a fantastic resource. So I highly recommend checking these two sites out. And then the CF Foundation has some PEP discussion guides available as well. And so I would encourage you to look at this. There's one on aiding people in having discussions about family planning. And these are available on cff.org in the resource library. So I'll move in and talk a little bit about fertility in females. So there's data that in the pre-highly effective modulator era that showed us that infertility rates in females with CF were higher at 37% compared to 15% prevalence in the general population. And it was thought that risk factors could include older age, pancreatic insufficiency, thickened cervical mucosa, an altered endometrial pH, changes with ovulation, or variability in ovarian reserve. And I'll touch on ovarian reserve for a minute. I think this is interesting. We have historically used anti-Mullerian hormone levels to assess ovarian reserve, and higher levels suggest a larger supply of eggs. Now, it's important to note this doesn't assess the quality of the egg or the overall fertility potential, but it helps you assess what how many eggs are present. And it's interesting because there's really mixed data in females with CF. I think this is an area that we will expand on in the future. Some studies show that in females with CF, these levels are lower, and then others show that more than 95% of females with CF have normal levels based on age. But historically, about 1/4 of females with CF have required assisted reproductive technology to conceive. Although if you think back to that graphic that I provided with the orange and the blue lines, this number has obviously dramatically increased since the approval of highly effective modulator therapy. But it's interesting to point out that comparative studies have looked at intrauterine insemination and compared it to in vitro fertilization. And intrauterine insemination is just as effective in females with CF, which really supports a cervical cause for infertility. So you'll have the pleasure of listening to another one of our speakers talk about male fertility and treatment options in a minute. And then I'm going to breeze over contraception because we'll have an entire 20 minutes on that. So I'll move in and talk about preconception and pregnancy. So there's several things that are suggested in the position paper of important considerations, especially regarding testing and consultation. And one, and this really mirrors the 2024 care model that says genetic counselors should be a really important and essential critical part of our care teams. But it's remembering that they can offer expertise, especially in this subject matter, and they can act as a liaison between the CF team, the prenatal teams, and the fertility specialist teams. And then also it's suggested that reproductive partners of people with CF should be at least offered testing with full CFTR sequencing. So there's a lot of information about optimizing health status before pregnancy. We know that preconception planning and pulmonary health and nutritional status optimization are associated with improved pregnancy outcomes. We know that if in people that's lung function is less than 50% are predicted, we know that that's associated with higher rates of morbidity and mortality. A BMI less than 22 has also been associated with more complications and poor outcomes. And then it's important for care team members to review the risks of pregnancy, including medication use, and make any necessary changes to the care plan, if possible, prior to conception. And so the CF team is a really important part of that decision-making process. And then obviously the maternal fetal medicine team are important players in that conversation as well. And then there are suggestions that pregnancy should be deferred at least 2 years post-transplant to reduce the risk of rejection and obstetric complications. So we know that data from the pre-modulator era have suggested that females with CF were at increased risk for preeclampsia or preterm labor, but post-modulator data shows us that there are improved outcomes in people taking highly effective modulators. To optimize health, it's suggested that females with CF are seen more frequently by the CF care team when they're pregnant. And so during the first and second trimesters, there's a consideration to see these women monthly with increased frequency during the third. And then it's generally thought that most of the medications that people with CF use chronically are considered safe or likely safe. So things like PERT, mucolytics, certain inhaled antibiotics, oral macrolides, and then ADEC vitamins are generally considered safe in pregnancy as long as the daily dose is less than 10,000 international units. So pregnant women with CF should be monitored really closely for nutritional status changes, and aggressive intervention is needed to ensure that there's adequate and appropriate weight gain during a pregnancy. Good glycemic control is also really important. There's data that that looks at hemoglobin A1C, and that definitely has associations with improved outcomes. And then the use of antibiotics is a conversation that I think is tricky, and care teams have to really navigate this and consider the risks and benefits in their individual patient case. And then I also pulled this out because I thought this was important to highlight, that it's important to recognize that CF isn't necessarily a contraindication to a vaginal delivery. And so I think this is an important statement, and not everyone realizes this, that the timing and mode of delivery can really be based on the individual's health status and other standard OB indications. There's some important postpartum considerations, like additional nutritional support from the dietitian and the rest of the team, especially if a mother with CF is breastfeeding. There is need for additional blood glucose monitoring. This is a really high-risk time for hypoglycemia in those with CFRD. And then obviously there's a significant importance for screening for anxiety and depression. And the CF care team could be involved in conversations about contraceptive options in the postpartum period as well. So I'll touch briefly on CFTR modulator exposure in utero and during lactation. We've heard a lot about this topic in the last few years, and so this is very high-level information. But we know that CFTR modulators do cross the placenta with cord blood concentrations similar to maternal levels. We also know that it transfers into breast milk, but at levels lower than seen in the cord blood. And we know that the majority of people with CF in high-income countries are eligible to take CFTR modulators based on variant, and many are choosing to continue them during pregnancy. And this really presents another opportunity for shared decision-making between the CF team and the women with CF. So safety has not been definitively established, but the individual risk-benefit consideration often favors continuing highly effective modulators during pregnancy. Most reports in the literature don't suggest increased delivery complications or adverse events. There are limited reports of cataracts and transaminitis in infants. And we're lucky to have the Mayflower study that's really going to further our understanding of CFTR modulator use in pregnant females with CF, both in utero and regarding neonatal exposures. And then I think it's important to note that CFTR modulators vary in their molecular structure. So favorable experiences with one medication should not necessarily be assumed to be a class effect. So it remains unknown if new compounds and new modulators will impact safety in pregnancy. So there's some suggested guidance for infants exposed to CFTR modulators in utero. And I've seen a lot of versions of this from different care teams and different centers. So I think centers are adopting various approaches to this. And so this is one potential approach, but it's important to monitor infants that have been exposed to modulators in utero. And so in the first 30 days of life for all infants, liver function testing is necessary, referral to an ophthalmologist should be considered, and standard neurodevelopmental assessments. And then I think a lot of people in the adult centers are probably experiencing mothers that are breastfeeding that are still taking highly effective modulators. And so those infants need liver function testing. And a suggestion is that could be done every month with eye exams every 6 months. And again, close attention to developmental milestones. So there are significant implications for newborn screening. We've heard a lot about this topic in the last 5 years as well. We know that CFTR modulators cross the placenta and they may preserve pancreatic exocrine function in the fetus. So our IRT-based assays can be falsely negative. And then we also know that exposure to modulators through breast milk can reduce sweat chloride values. And on top of that, there's variability in parental carrier testing and genetic counseling and prenatal testing. And so all of these factors, when you consider all of them together, it makes a case for the consideration of doing CFTR sequencing in the modulator-exposed newborn. And this presents a great opportunity for collaboration between pediatric and adult centers, PCPs, and newborn screening labs. So I'm wrapping up the end of my talk before I pass it on to my colleagues, but I wanted to highlight a few publications if this is an area of interest for you, and it might be since you're sitting here on a Saturday morning, but I wanted to highlight 4 publications that I really like that have shed a lot of light and a lot of really important insight on these topics. So these 2 are excellent, and then I wanted to highlight these 2 publications. And then I wanted to give a shout out for the members of the Sexual and Reproductive Health Position Paper Committee. And the way that we're going to do this symposium session is we're going to save the Q&A for the end. And so hopefully we'll have some nice discussion and nice questions after all of us have presented, but feel free to email me at any time down the road.
All right. I have the privilege of introducing our next speaker. Dr. Danielle Velez-Leitner is a reproductive urologist and director of men's health at Rutgers Robert Wood Johnson Hospital in New Jersey, specializing in male infertility and sexual dysfunction. She completed her urology residency at Brown University, Rhode Island Hospital, and then a fellowship at the University of Illinois at Chicago in male infertility and sexual dysfunction. She's now an assistant professor at Rutgers. The majority of her research focuses on sexual and reproductive health in men with cystic fibrosis. In 2022, she was nominated to serve on the Cystic Fibrosis Foundation's TDN, Sexual Health, Reproduction, and Gender Research Working Group, otherwise known as SHARING, a multidisciplinary team of CF clinicians, researchers, and patients who identify knowledge gaps, determine research priorities, and develop infrastructure needed to conduct research related to CF and sexual, reproductive, and gender health. Through SHARING, we have surveyed men and women with CF on their specific sexual and reproductive health concerns. This has led to an ongoing retrospective review of sperm retrieval rates and embryo outcomes for men with CF and database studies on the prevalence of hypogonadism in men with CF.
Hi, everybody. Good morning. Thank you for joining us on a Saturday, rainy Saturday, but Saturday. So I do have two disclosures. One is my SHARING grant recipient status and also Envision. So I owe a lot to the Cystic Fibrosis Foundation for giving me the opportunity to learn so much about this population and how urologists can really help to support their care. And this year, we also received a grant from the Boomer Esiason Foundation to help build out those retrospective studies on sperm parameters in males with CF. So today, talking about reproductive health in males with CF, let's go into options for family building and also men's health. I want to go over sperm extraction techniques and ART options for men with CBAVD. We'll go over reproductive outcomes in terms of what we know so far and where we're going. And then we'll discuss options for testosterone supplementation. I should back up, and I didn't include this in the slides, but I really liked what Ellen was saying in that there is a variety of family building paths. And of course, for certain families, they're not going to want biological children. You may be able to want to explore adoption or gamete donation, whether that's egg or sperm donation. But for the purposes of this talk, we're really going to talk about biological parenthood. So we know that 95% of males with CF have obstructive azoospermia. And what that means is that with ejaculation, we are unlikely to see sperm inside that ejaculate. And that really comes down to the CF anatomy. One is that it's very common for men to have CBAVD, or congenital bilateral absence of the vas deferens. Commonly, we can also see pore formation or hypoplasia of the seminal vesicles, which are these little ears coming off of the back of the prostate that are responsible for making most of the ejaculatory fluid. We can also see a hypoplastic or a poorly formed epididymis, which is really where sperm learn how to swim and mature. And then finally, we can sometimes see ejaculatory duct obstruction, which are these tiny little tubes that drain all of that ejaculate into the urethra. The fertility impact here is that we often see no sperm in the ejaculate. We often see low volume ejaculate, which tends to be that patient's first clue that there's a problem. And then on my side in the lab, I see low pH in the ejaculate. Luckily, most males with CF do make sperm. They just don't have a highway for it to get out. So we have a lot of ways of retrieving it. The way I think about it are we can aspirate, meaning we stick a needle into an organ and pull out a couple of cells, or we can do a little bit more of an incision where we go digging. So we tend to think about this as office-based sperm retrievals versus surgical, although I will preface this by saying that many of my reproductive urology colleagues are pushing the boundaries in terms of what we can get away with in the office, because it often means for lower cost and easier logistics for that couple. With a percutaneous epididymal sperm aspiration, you can see on the left, this is called a PESA. for short. We're basically numbing the scrotum with some lidocaine. So I'll tell patients you're going to feel a big pinch and then some burning, and then you shouldn't feel anything other than touch after that. And that usually takes about 30 seconds. We're sticking an angiocath or a butterfly needle into the head of the epididymis, and then an assistant is aspirating out fluid. We're handing it over to a lab where they hopefully find sperm for IVF. We can also do this into the testicle. This is called a TESA or a TESA, where we're taking a larger gauge needle, going directly into the testis and taking out a single tube, a seminiferous tubule for sperm extraction. In terms of surgical sperm retrievals, that we think of more of an incision. So in the middle image, you see a TESE or a TESE. This is a small incision. It's about 1 centimeter in width. Again, we've done this in the OR. We've done this in the office with the right tools, numbing the skin, numbing the testicle, very well tolerated. I tell my patients, you will definitely walk out of my office after this. You may just walk like a cowboy. But with that 1 centimeter incision, we can usually pull up a couple of tubes, and assuming that the factory is on and that they're chock full of sperm, that patient should find enough in there for IVF. We save the other two options, so MESA and a microtessie on the either end of that slide, for more severe cases of infertility. So this is where we're more concerned. Maybe I can't just blindly throw a dart and pick up sperm. Maybe I need to be more precise. So with a MESA or a microsurgical epididymal aspiration, we're usually taking that patient to the OR, putting them to sleep, delivering the testicle through a little bit of a bigger incision, so maybe 3 to 4 centimeters, and then trying to use a microscope to isolate a few dilated tubes of epididymis so that we can more precisely aspirate out and send to the lab. Microtesses all the way to the right. These are usually reserved for cases where we're really concerned that we might not make a lot of sperm. So this is the most invasive option that we have. It usually takes 1 hour to 2 hours, where we're opening up both testicles, we're looking under a microscope, and the way I describe it to my residents is you're going to see a sea of ramen noodles, and your job is to find the bucatini. Okay, because that's the spot, that's the most likely place to find sperm. A lot of my patients with cystic fibrosis will ask, well, what is everybody else doing? What's the best option? I only ever want to do this once. How can we guarantee that? The answer is we can't. But I also said, I have no idea. So we thought we would survey our society for the study of male reproduction to see what are all of you guys doing across the country. We had 51 survey responses, and we found that it's kind of all over the place. There is 31% of urologists said that they'll do a combination procedure. Well, they'll check the testis, they'll check the epididymis, whatever we find is what we find. 39% will go directly to the testicle, probably because we often see poor formation of the epididymis, so that may not be a good option. And about 29% said, we'll try for the epididymis and see what we get. And there was a pretty even split between extractions versus aspirations. Pretty even split between local anesthetic in the office versus operating room. One comment that was made was, we try to do this in the office because there's a lot of bias amongst our anesthesiologists that when they see that cystic fibrosis diagnosis, they are concerned they may not be able to do these procedures in a surgery center, which is what most fertility clinics are. And they may punt that patient to a main operating room in a hospital, which becomes more of a logistical burden. Interestingly, 90% of reproductive urologists will check baseline fertility labs. You'll hear me talk a lot about testosterone today too, and this concern that maybe our guys aren't getting their T levels checked. If you get them to a urologist, we will certainly check for you. And those baseline fertility labs, if anyone wants to know for their own CF clinic, we typically will look for a total testosterone, estrogen, an FSH, and then an LH. And those should be early morning draws. But because sperm acquire motility after they complete their transit through the epididymis, couples have to rely on IVF with intracytoplasmic sperm injection, or ICSI, in order to form those embryos. So it's not enough to just get the sperm. If we're taking it from the testis or even some parts of the epididymis, we can't just put it inside a petri dish. We have to actually take a single cell and inject it directly into a single egg. One question we had as we embarked on this position paper journey was, are all obstructive azoospermia cases equal? So if I have a guy with CF who's obstructed, and I compare that to a guy who's maybe had a vasectomy and changed his mind and decided we actually want a couple more kids, are those outcomes the same? We don't entirely know, but we don't think so. We have a couple of studies that show that there is a positive correlation between CFTR expression on the sperm and sperm motility and morphology, which are poor men's markers for sperm quality. So the more CFTR you have on that cell, more functional CFTR, the better the sperm motility and shape are. We know that in healthy controls, if we add CFTR inhibitors, so we take that off the table to the sperm cells, we actually prevent the acrosome reaction, which is the necessary step for fertilization of an egg, which maybe we get past with ICSI. But then when we look at CFTR knockout mice in the lab, we see that they have lower testis weight, which is a good approximation for fertility. The heavier or the bigger the testicle, the more sperm that testicle is probably holding. We see lower daily sperm production. We see worse epididymal sperm extraction, even in the setting of a normal epididymis. And we see downregulation or loss of key sperm-forming factors, which sets us up for the question of maybe it's not just a delivery issue. Maybe it's also a little bit of a production issue. When we move out of the lab and into real-life outcomes, we don't have that many studies. As I think Kevin noted, this is a struggle. We have data collection from multiple places. It represents a lot of complexity of care issues. So it's hard to get this data, but we do have some. So looking back at 2 separate andrology practices, this was before the era of highly effective modulator therapy. We were able to identify 10 males with CF and compare them to 29 with CBAVD. So maybe they were a carrier, but they didn't have full-blown CF. We found that more men with CF had to default to a rescue TESI or micro-TESI because they couldn't find sufficient sperm with just going after the epididymis, which as a urologist we look at, we translate as maybe there is a production problem here. We saw lower sperm extractions with MESAs, and then more importantly, we saw lower fertilization rates in the CF patients, meaning that if you start with, in an IVF cycle, let's say 10 eggs, the first step that's going to drop off is, well, how many of those eggs fertilize? And that usually happens on day 1 of that cycle. And then we follow those out, and on around day 3 to day 5, we say, well, how many progress to a blastocyst? And the blastocyst is the embryo that you're going to freeze or transfer for hopeful pregnancy. So if we have that big drop-off from egg to fertilize, you're not going to form as many embryos for that couple as you are in maybe your CBAVD patient, where you've got a 69% fertilization rate. Thankfully, we saw similar live birth rates between the 2 groups. And unsurprisingly, the patients with the worst CF had the lowest fertilization rates, lowest pregnancy rates per cycle, and the lowest live birth rates. More recently, we pulled our data from Penn and Cleveland Clinic. This is the post-highly effective modulator therapy era. And we're not entirely sure how to interpret this because they are very small numbers. But I think the key takeaways that we found were that the FSH, or the follicle-stimulating hormone levels for our CF patients was significantly, well, actually it wasn't significant, but it was higher at 10.5 compared to our carriers versus our CBAVD patients. For urologists, when we see an FSH over 7.6, that to us, that really indicates sperm production problem. When we did a subgroup analysis looking at just our CF patients and comparing those on highly effective modulator therapy versus not, the people who were on therapy were less likely to have that spermatogenic dysfunction. So it's 14% versus 80% of our non-therapy patients. And then finally, looking back at the therapy versus not therapy, our modular therapy couples had a higher frequency of a positive pregnancy test per transfer compared to our not therapy patients. When we look at just that, well, how much sperm are we getting out of these patients for this study? This is a little bit more difficult to interpret, but if you look over at the left-hand side, that first big red box is looking at 70% of our men with CF having very, very few sperm in their extractions. And this is a problem because if we have certain labs will say, look, this is the smallest cell in the human body. If you only give me 10 cells, I can't guarantee you that when I thaw that sample, I can find those 10 cells again. So that may indicate a failed retrieval down the line. Versus if you look at our patients who don't have a CF mutation, they just had CBAVD, you can see that only about 20% of those patients had very few extractions. Very few sperm on their extraction. The good news is that ultimately what we care about is what is that take-home baby rate? What is your pregnancy outcome? And in 2024, we looked at 71 men with CF who were referred to fertility services over a 22-year period. And we saw that there was a 98% sperm recovery. So we might not have found a lot, but we found something. There was only one failed aspiration. 94% of couples went through the ICSI process with an 84% pregnancy rate. That yielded 59 live births, of which 3 were twins. So ultimately, we think we can get these couples pregnant. We can give them babies. But I think the question becomes, how many times are you going to have to do this process to really build your family? How early can we get you into reproductive urology so that we can do our evaluations, counsel you, prepare you? Because we know that this is a process that's not a walk in the park. It requires finances, it requires physical preparation, it requires a lot of logistics, and it may take time. For example, for our guys who have low testosterone, if we have to normalize that testosterone to really optimize retrieval outcomes, that can take months, and that also requires sometimes a lot of funding. But the good news is that for men with CF, modulator therapy looks like it might actually improve fertilization and transfer outcomes. So I think we're moving in the right direction. In terms of referral, I know a lot of centers will often ask, well, how do we find you? There's not that many of us in the country. But if you go to the ASRM, that's our main governing body, and if you want to screenshot this website, it is very easy to find a health professional. You can toggle by urology, by state, by zip code. There are even, I call them traveling urologist, telemedicine options. They're called Posterity Health, Posterity. They're great. They have licenses in multiple states. They can get the process going for you quickly over a telemedicine visit and then coordinate a sperm extraction in person going to that patient, usually within a couple of weeks' notice. So shifting some gears for the last few minutes of my talk, we know that low testosterone is something that we've really been concerned about for our patients with CF. Really briefly, we diagnose low testosterone based off of lab values as well as signs and symptoms, and you can see that there are many things that show up in low T that also show up in males with CF. So bone density loss is a concern, diabetes, chronic steroid use or exposure, and then male infertility, 98% of that population. We know that testosterone fluctuates over a course of our lifetime, over the course of the year, over the course of the day. So we really harp on getting 2 early morning blood draws, ideally before 10 in the morning. Not for nothing, most insurance plans won't pay for testosterone supplementation unless you prove that there are 2 draws before 10 a.m. We think that hypogonadism is pretty prevalent in males with CF, especially at a lower age. This is, again, difficult to prove because we don't have large population studies. They're poorly designed and that we can't always guarantee that's that early morning draw. But it seems like it's pretty consistently coming out around 25 to 35%. How do we treat it? Okay, so I think this is something that's also kind of surprising for some providers and patients because they think, oh, I just need high testosterone, I'll be fine. But the answer is that if you give testosterone gels, injections, sometimes even pills, that's the closest thing we have to male birth control. Over the following couple of months, you're going to really drive that sperm production down to 0. And that happens because testosterone in the bloodstream is going to shut down the anterior central axis so that we basically don't make sperm and we don't make normal levels of T within the testicle. The good news is that we can usually get that sperm production back, but it's a little bit of a painful process for our patients, and it can take time, sometimes 4 to 18 months of alternative medications to restart the hypothalamic pituitary gonadal axis and then spermatogenesis. We do have several fertility preserving options for testosterone. We rely on selective estrogen receptor modulators. There are aromatase inhibitors. If those fail, and those are nice first line options because they're pills. But if they fail, we can back into HCG injections, which are given a couple of times per week. There's also this question of maybe intranasal testosterone sprays being useful. These are basically given 2 to 3 times per day. They're very short acting, so the half-life is only about 100 minutes. But because it's so short, we think we don't lose the normal stimulation of the pituitary. And so we're seeing that 90% of men stay eugonadal after 6 months. In other words, they're getting good testosterone levels. And about 85 to 90% are going to maintain some sperm production. So it may not be as high as it was before they were on their medication, but we're not going to drive it to 0 like we would with a gel or an injection. A quick note on logistics again. So these medications are unfortunately very expensive. I pulled these prices back in January. When I rechecked in August, they weren't that off. But these are monthly prices. And for certain patients, we may need to be on these meds for 3 to 4 months before we can really say that we have optimized that sperm production before going into an extraction. And as you know, we have that additional barrier of, I can't just ask for a semen analysis. I have to go poking and prodding to be able to get results. So for most of my couples, it's very much a shared decision-making plan, but most of them are saying, we would like to just do this once. We'd like to optimize this as much as we can. So getting in to see me earlier, even by a couple of months, is always a little bit better. There are many financial barriers. Hopefully those are starting to go away, but as of August 2025, only 23 states in Washington, D.C. had some fertility insurance coverage law, and these mandates really vary from state to state. Thankfully, there are a lot of options for support. So I think the CF Foundation Compass is a great place to start. They'll help you to understand insurance options. And when it comes time for open enrollment, if that's the year your couple is thinking we might want to try to get pregnant, they should really pay attention to what plans offer which fertility support benefits. There are also grants available. So the Boomer Esiason Foundation is one of them. Philatimo is another. So patients can use these to see if they qualify and really look around locally. Sometimes even local fertility clinics will offer some grant funding for a smaller study to support that IVF process. So again, all males with CF are unfortunately inherently fertile because of the CBAVD. We do not think this is going to change with adolescent or adult administration of highly effective modulator therapies. But we do think that those therapies may help to support reproductive outcomes for the patients. Connect with us early. I think that ASRM is a great resource to be able to find a reproductive urologist. Even if you find just a regular urologist, they can probably get you at least going on that journey. And then just remember that couples in which the male partner has CF are going to have to rely on IVF ICSI for their biological children. There are many ways to build families, and I tell couples this all the time along their journey. But it's important that they pay attention to insurance coverage, know about outside support programs, and I think really relying on you guys on that team as their first source of information and a trusted referral, hopefully to a community urology partner, is always the best first step and best practice for patients.
Thank you, Danny. That was great. Okay, I have the pleasure to introduce our next speaker, also one of your co-moderators. So Kevin Lonaba is an ambulatory clinical pharmacist in both the pediatric and adult CF centers at the University of Virginia in Charlottesville. Originally from New Jersey, Kevin completed his bachelor's degree at the College of William and Mary before completing his pharmacy degree at Shenandoah University in Winchester, Virginia. He then went on to complete a PGY1 pharmacy residency at UVA Health and a PGY2 AmCare Pharm residency at the University of Oklahoma College of Pharmacy. He returned to UVA in 2017, first as a member of a pediatric pharmacy team before transitioning to his role at the UVA specialty pharmacy in the fall of 2022, and this allowed him to practice in both the pediatric and the adult CF centers. His clinical interests include patient education and optimizing the transition between pediatric and adult care.
Good morning again, and thank you so much for that introduction. I'm very excited to talk to you all today a little bit about contraception. I think it's a topic that's going to be coming up more and more in our CF centers, and I think our team should be aware of some of these high-level topics to be able to start the conversations with people with CF. So I do have a few objectives. I have no disclosures. I do have a few objectives that I want to cover. My first objective is to talk about what contraception use looks like amongst females with CF currently. We'll talk about different options for contraception and things to consider, especially for females with cystic fibrosis. And then we'll also be listing some pertinent drug interactions to think about between contraception and the medications that we use for their standard CF care. So why are we talking about contraception at NACFC? Why is this an important topic? Well, we know that the number of pregnancies has gone up in recent years. And we know that with the introduction of CFTR modulators, females with cystic fibrosis are perhaps more fertile than ever. We also know that there are high rates of unplanned pregnancies amongst many females with cystic fibrosis. And there are risks inherently associated with those unplanned pregnancies. These include higher rates of pulmonary exacerbations and infants who are more likely to be either preterm or have lower APGAR scores. Another thing that we know from the literature is that contraception use amongst females with cystic fibrosis is perhaps lower than the general population. In one survey of women 25 to 49 years old, the rate of contraception use amongst females with cystic fibrosis was only at 43%, compared to 76% amongst their similar peers in the general population. And that was despite similar rates of sexual activity. And interestingly enough, this survey did highlight that many of these females had used contraception at some point, but had chosen to discontinue it for one reason or another. There's also reports that about 25% of females with cystic fibrosis have fewer CF symptoms or worse CF symptoms during their menstrual cycle. So regulating that menstrual cycle may help with some of these symptoms. There's potentially a protective benefit, as women on combined oral contraceptives have decreased pro-inflammatory cytokines during the ovulation phase, and at least one study has suggested that there are decreased rates of hemoptysis with the use of contraception. And then finally, we want to ensure reproductive justice. Now, reproductive justice is defined as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we do have in safe and sustainable communities. This is really important to allow our patients the opportunities to choose if and when to have children, to enable individual choice regarding their education and career development, and to improve overall family living circumstances. What does contraception use look like amongst females with CF? Well, we have several studies that have tried to answer that question. So this slide highlights a variety of surveys, both online and in the clinic, both written and on web-based formats, in women both here in the United States as well as abroad in France. And what they found on the whole is that the most common method does tend to be our combined hormonal contraceptives, specifically combined oral contraceptive pills. We do see condoms being utilized as a secondary option, and that is probably the second most common type we see that used. And then finally, while it's not one of the most common methods used, we do see relatively high rates of long-acting reversible contraception amongst females with cystic fibrosis. I really want to highlight this survey because I do feel like it's a reason for why we're having this conversation here at NACFC, which a 2023 study by Kesmersky and colleagues showed that 30% of female actually received counseling regarding contraceptive from the CF care team. So even if we're not the ones prescribing this contraception, we are trusted partners and they rely on the information that we're providing in the CF team. Finally, about a quarter actually received their method of contraception from the CF care team, and a third took a pregnancy test at the CF clinic. I also want to introduce the concept of a contraceptive desert, because as CF care teams, we can serve as an extension of care for people with CF. So contraceptive deserts are counties where the number of health centers does not meet the needs of women eligible for publicly funded contraception. And that's going to affect about 19 million women in the United States who live in these areas. The lack of access for contraception means the lack of ability to safely and effectively prevent pregnancy when not wanted. We also see that there are a variety of different methods that women may be accessing contraception now, which means the information that we're providing in clinic may be even more important than it was previously. This can include things like telehealth, pharmacist prescription of contraception. So in 2015, Oregon, just down to the south, was the first state to allow for pharmacist prescription of contraception. And within a year, over 74.5% of the prescriptions from pharmacists were actually people that had not used contraception within the previous year. In addition, that within 2 years, it was estimated to have saved the state over $1 million and stopped 51 unplanned pregnancies. There's over-the-counter options for contraception in both the United Kingdom and the United States, with the approval of Norgestrel, or a brand trademarked under the brand O-Pill, that was approved in 2023 and released on the market in 2024. And there's a variety of web-based resources that females may access to obtain contraception. So the conversations that we're having in clinic become even more vitally important. This is a map that shows the states that allow for pharmacist prescription of contraception. And I do want to highlight that this is meant to be an extension of primary care, not a replacement. It does require additional training and requirements for the pharmacists that provide that contraception. So there are, and that's going to vary state by state. But at this point in time, there's over 30 states, as well as the District of Columbia, that will allow for some capability of pharmacists to prescribe contraception. So as we start the conversation about what to use and what contraceptive method is best for our individual with cystic fibrosis, we want to think about a few key things. We want to think about what comorbidities are present. Do they have liver disease? Do they have diabetes? Are there other things that may affect their choice of contraception? What other medications are they taking, both for their cystic fibrosis as well as other conditions that they might have? What does the efficacy look like? And how important is that to that particular individual? Do they want the most effective method available, or they want something that's more convenient for them? And what are the frequency and adherence requirements? Especially in light of an already extensive medication regimen, what's going to be feasible for that individual? And then finally, thinking about the side effect profile. So that actually is oftentimes one of the most important factors when women are considering their contraceptive choice in a lot of surveys. And so thinking about the side effects that are important to them. I do want to highlight the medical eligibility criteria, which helps kind of categorize how safe a particular type of contraception is according to individual characteristics or medical conditions. And this ranges all the way from category 1, where there's no restrictions, to category 4, where methods should not be used because unacceptable health risks exist. I do also want to highlight that just because a method is perhaps a category 2 and you've got another option that's a category 1 doesn't mean that the category 1 option is the best method for that patient. It just means it might be the safest method for that patient. But individual characteristics may influence your choice. Cystic fibrosis actually has its own category in the medical eligibility criteria. And I think this underscores the fact that we can utilize many contraceptive options for women with cystic fibrosis. All forms, with the exception of medroxyprogesterone injections, are actually category 1. And I do want to highlight, though, that if our females with cystic fibrosis have additional comorbidities such as liver disease or they're breastfeeding, we should use those recommendations for the other conditions. This table highlights the efficacy, with our long-acting methods being really our most effective with typical use, over 99% effective, and our estrogen-containing methods being around 91% effective with typical use. We see more variability when we talk about barrier and behavioral methods, but as these are hormone-free options and don't have drug interactions, they may be an option for some females with cystic fibrosis. And with perfect use, we can obtain higher levels of efficacy. This diagram comes from the CF Foundation's Birth Control Guide for People with CF, and I really highlight this as a great resource for our teams as they start to have these conversations with women with CF, because it provides an overview both for us as clinicians, but also for females considering their options. And this diagram highlights the available methods in terms of efficacy. So we'll start out by talking about estrogen-containing contraception. So this method suppresses ovulation through a negative feedback loop on the hypothalamus to decrease production of follicle-stimulating hormone and luteinizing hormone. There are contraindications for estrogen-containing contraception, including certain types of cancers like breast cancer, endometrial cancer, and liver cancer, as well as significant hepatic disease or those that are at high risk for venous thromboembolism. The most common side effects with estrogen-containing contraception are going to be breakthrough bleeding, nausea, vomiting, and headache, with additional side effects including rash, mood changes, dyslipidemia, or venous thromboembolism. Weight gain is also possible with estrogen-containing contraception, and then I'm going to start by our most frequent administration for combined contraception and estrogen-containing contraception, and then move to ones that are less frequently administered. So we'll start by talking about the combined oral contraceptives. These are daily administered. They do have drug interactions because both estrogen and progesterone are substrates of CYP3A4. The key interactions that I want to highlight here are going to be lumacaftor, ivacaftor, or brand name Orkambi, and rifampin, as these are both CYP3A4 inducers that are going to make this method less effective. While the daily administration may be an additional burden for some, there's a lot of flexibility because the different products have different amounts of estrogen and progestin, and they also use different types of estrogen and progestin. So just because one pill doesn't work for an individual doesn't mean that there's not an option out there for someone. As we start to lengthen out our administration time, the patch is available for weekly administration, but it shouldn't be used for those with a BMI above 30 kilograms per meter squared. We also should note that there's an additional risk for skin irritation at the site of patch placement, so if we have an individual who's more prone to rashes or skin irritation, they may not be the best option. And there are actually 2 products out there on the market now. The vaginal ring has 2 formulations available. One, which is you insert a new ring every cycle, and the other one, a new ring is inserted every year. It can be left inserted during sex or during menses, and can be used with both tampons or pads. A backup method of contraception is required if it's taken out for even a short amount of time, so only 3 hours for the every cycle product or every 2 hours for the every year product. And now we'll switch gears to talk about progestin methods. So these are going to thicken cervical mucus to inhibit sperm passage, inhibit sperm survival, and alter the surface of the endometrium. A lot of times progestin methods were used for those that were, and we'll start out by talking about the progestin-only oral contraceptive or the sometimes called the mini pill. A lot of times this method was used for women considered to be subfertile, so those that were lactating, and cystic fibrosis was also at some points considered a subfertile condition. That's both a misconception in the utility of this product, as they are just as effective as our combined methods, as well as what we know about women with CF today, as we know that fertility has increased. Now, this method is available over the counter. As I mentioned, norgestrel is available here in the United States, and then desogestrel is available in the United Kingdom. And it still is most often used for those with contraindications to estrogen-containing contraception, such as those at risk for venous thromboembolism. Some of the myths I want to highlight here are that it's less effective than combined oral contraceptives, because that is not true. And there also was a historical concern that the dosing window, you had to give them within a 3-hour period, or you needed a backup method of contraception. And newer evidence suggests that perhaps these are more forgiving than we once initially thought. Advantage over the progestin-only pills include that they're compatible with lactation, they provide a quick return to fertility, there's no risk for VTE, and they are highly accessible as they're available over the counter. But disadvantages are going to include irregular bleeding, daily administration, as well as drug interactions, such as those with lumacaftor, ivacaftor, and rifampin. We'll now spend a few moments talking about medroxyprogesterone injections, which is available in both subcutaneous and intramuscular injections. The subcutaneous product can be self-administered at home, and the dosing frequency for this is going to be anywhere from 12 to 14 weeks. Now, medroxyprogesterone does carry a black box warning for loss of bone mineral density. And we know that this is a risk for people with cystic fibrosis. And so this actually will increase with the duration of use and may not be reversible. So that has led to it being listed as both a category 2 for people with cystic fibrosis, as well as a black box warning. It's not recommended for use more than 2 years if other options exist, stemming again from the concerns for bone mineral density loss. I do view this as a key opportunity for partnering. So if women with CF are using this method and they really like it, it's worked well for them, and they want to continue, I think this is an opportunity for us to talk about the benefits and risks and see if this is the best option for them. And if they do want to continue, figure out a plan to monitor their calcium and vitamin D intake more closely, as well as recommend weight-bearing exercises. This option does have some advantages in the cystic fibrosis population. Weight gain, which is actually more prevalent for those that are younger and underweight, may be an advantage for some of our individuals with cystic fibrosis. It tends to be minimal in the first year of use, but over time does tend to develop more. And there's at least one abstract that's been published that suggests that maybe the use of these agents actually decreases the risk for pancreatitis. So interestingly enough, medroxyprogesterone may play a role in protecting against that complication. Long-acting reversible methods of contraception are going to be our most effective methods with typical use, and it is important to present these as an option for all women considering contraceptive choices. They provide a rapid return to fertility on removal, and they include both the implant and intrauterine devices. We have a variety of formulations out there on the market. I think it's sometimes a little surprising when we start to think about just how many intrauterine devices there are. And you can see, what I want to highlight is that they can be used for a long duration, up to 8 years for our hormonal product and up to 10 years for the copper IUD. Now, the Myodela copper IUD product was just approved this year, and it's the smallest IUD available and has a more flexible frame. The implant is one of our other methods of long-acting reversible contraception, and it is inserted into the inner part of the non-dominant arm. It does require a procedure with local anesthesia, and we should consider avoiding line placement on the arm where the implant is inserted. So this is an important consideration for someone undergoing an exacerbation who may require IV antibiotics. Now, the intrauterine devices are also going to require placement by a trained professional in a healthcare setting, and we do see higher rates of this use in the CF population. It is possible that it may be a little bit of an artifact of survey bias. Many of the women surveyed in some of those earlier studies are at centers with high rates of clinical trial participation, in which case highly effective methods do need to be utilized. But regardless, this is a great option for women that want something that doesn't require a lot of thought and provides protection long term. There's a lot of common concerns that I think we can help to dispel some of those myths and concerns, including a permanent loss of fertility. That's a misconception, as well as misunderstandings about the insertion process and fears with a foreign object in the body. The copper IUD's biggest advantage is that it's hormone-free, so it doesn't have drug-drug interactions. It is going to work by interfering with sperm transport, therefore decreasing fertilization and preventing implantation. It is not going to affect ovulation. I do want to spend just a moment to discuss the fact that adolescents can use intrauterine devices, and the American Academy of Pediatrics really supports them as part of the discussion regarding contraception, especially in light that these options are underutilized by adolescents. They are at a slightly higher risk when we look at the medical eligibility criteria. They're considered category 2 because there's a slightly higher risk for expulsion, and there's a higher baseline rate of STIs. I do want to note that STI screening doesn't have to be completed before an IUD is inserted, but there are slightly higher risks when present. And then finally, we'll wrap up by mentioning our barrier and behavioral methods, which are an option that might be the right choice for an individual who's seeking something that's hormone-free and also provides, can potentially also provide some sexually transmitted infection prevention. Some of these methods, including the diaphragm and vaginal gel, do still require a prescription. Emergency contraception is safe and effective for females with CF, but we do want to note the timing. So our levonorgestrel over-the-counter product must be used within 3 days of unprotected intercourse, and it may be less effective for those women with a higher BMI. and the ulipristal, which is prescription only, is also potentially less effective for those women with higher BMIs above 30. In the postpartum period, all progestin-based methods can be administered, and IUDs can actually be placed within 10 minutes of delivery. So planning even before that delivery may be important. So we'll talk just a moment about drug interactions. These are the ones that I really want you to remember. These are the ones that are going to either decrease efficacy and potentially need a backup method, or increase concentrations and cause potential more side effects. Those that decrease efficacy are going to boost metabolism of hormonal contraception and include rifampin, St. John's wort, griseofulvin, nirmatrelvir ritonavir or Paxlovid, and then mycophenolate use in the transplant population. Azole antifungals such as voriconazole are going to increase the concentrations and potentially put women more at risk for side effects. Now, I do want to highlight something. Pancreatic enzymes do not interact with oral contraception, and women with CF can safely use oral methods. This was a previous myth, but really the current birth control guide for people with CF does highlight that it is safe and effective for women with CF to use oral methods. Now, this slide shows another common myth. Antibiotics are mostly fine with hormonal contraception. So we know that we use a lot of antibiotics on a regular basis, and most of them are just fine. Really, the only ones that require a backup method are going to be rifampin, its cousin rifabutin, and then griseofulvin, an antifungal. When we talk about modulators, the only modulator that is going to cause problems is going to be lumacaftor, as it's a CYP3A4 inducer. Lumacaftor, ivacaftor decreases the efficacy of all types of hormonal birth control, but non-hormonal methods may be utilized. And we may see an increased incidence of rash with the use of ETI in women on hormonal contraception, particularly at initiation. I'll just close my part of our session today with a few words on counseling that our next speakers are really going to drive home and provide a great overview for. But when we're having these conversations, I presented a lot of information to you today, and it's can be a little bit overwhelming, but we want to really use our partnering skills here. Open up the conversation with open-ended questions to identify personal goals and use shared decision-making methods to find the particular method that is right for that individual. Methods can include the gather framework, one key question, or the path framework. And the one key question method traditionally has been, would you like to become pregnant in the next year? But can be altered or adapted to, would you ever like to become a parent someday? To get an idea about an individual's future reproductive plans and what is most important for them to talk about at that particular encounter. So clinician resources, I think many of us would recommend CFresh, and we can't say enough about how useful it is, but I do want to also plug the CF Foundation's birth control guide for people with CF. And then in summary, contraception is an important component in discussions surrounding sexual and reproductive health. Females with CF can safely utilize most forms of contraception, so we've got a full arsenal of tools at our disposal to talk about. And CF care teams can really help foster the conversation about contraception with females with cystic fibrosis to both dispel myths and enable females with CF to find the methods that meet their own individual goals. Thank you so much for your time.
Thank you, Kevin. That was amazing. I'm really excited to introduce our last speakers. And we're lucky to have two speakers for this part of the symposium session. I'll introduce them both at once. So first we have Abby Meacham. Abby is a clinical social worker at the Pediatric CF Center at the Children's Hospital of Orange County in California. She completed her undergrad and graduate studies at UCLA, and she spent almost half of her 16 years of social work working within the CF community. So she's really passionate about people with CF. In addition, she's the social worker for the PCD patients and cancer survivorship teams at CHOC. And then her co-presenter is Maeve Sue, who's the CF program coordinator and PCD nurse care coordinator at CHOC as well. She earned her bachelor's degree in nursing from the University of California in 2010 and her master's from California State University. She joined the CF team as the coordinator in 2015, so she has a lot of great insight for us. And in 2022, she accepted a role as a PCD nurse coordinator in their newly established PCD clinic. So welcome both Maeve and Abby.
Hi, thank you so much for having us. Maeve and I are excited to talk about the project our team's been working on sexual and reproductive health. I'll start us off, and then I will hand it over to Maeve. There are no relationships to disclose. So we first realized that we had a gap in our education in terms of sexual and reproductive health back in fall of 2022. When we were administering transition readiness assessments for patients aged 12 and up, we realized that we were totally avoiding the section on reproduction, and we had skipped asking questions about fertility for like almost 3/4 of our patients. This wasn't because we didn't care or we didn't think it was important. It's just we were totally unprepared. So it wasn't part of our formal education at that point. So we didn't have a process in place. We didn't have any educational tools. We didn't have the most up-to-date research. The worst part for me is that I didn't know what the patients knew. So we were like walking into the room blind. But at that point, we realized it's time that we really had to make a change. So we started a quality improvement project with a global aim to standardize and normalize SRH discussions in our clinic more immediately to focus on catching up because we were really behind, and then a more long-term focus on creating a sustainable approach. So as we got started, I feel like the first thing we wanted to figure out was what patients know and then educate. So in 2023, when we started with our young adult patients first, and then in that year moved down to 16 and 17-year-olds. And for educational tools, we used CF RISE, the Sexual Health Knowledge Assessments. And CF RISE is a program that helps prepare patients transition from pediatric to adult care. So our idea was to administer these assessments one-to-one. It would either be our pulmonologist, our nurse practitioners, or Maeve or myself. But then we also added some supplemental questions that you can see up there. Some of them are like, have you ever thought about having a family? Or have you ever looked up this information before, and where? After we did those assessments, we would educate, and then maybe a few visits later, we would reassess and re-educate as they needed. But having tools in place is one thing, but the reality of making SRH a standard part of our care really required our center culture to go through change. We had to adjust our clinic flow to allow for additional time for confidential information. We had to create space in our education to really recognize that SRH is a priority in pediatric CF care, and we had to prepare our patients and families for what to expect. So we started introducing topics to patients and families in visits and saying, hey, this is what we're going to be talking to you guys about in a few visits, just to prep them. And then we would even meet with caregivers ahead of time. Some needed a little extra support and prep, so we might call them ahead of time. We also wanted our families to know that our adolescents have the right to have access to their health education, and that the importance of the patient's role in their care. So luckily we have a hospital transition policy, which is up there on the right, that says just that. So we email blasted that to all of our patients. We reviewed it with our patients and families in clinic. No amount of preparation was too much at this point because we were really far behind. Partnership has also been an important part of our project. Our PFAC is very small but mighty, and we included them in the entire process of this project. We partnered with adolescent medicine and urology for referrals, and then we coordinated with primary care frequently. We partnered with our patients and families, right? Some of them had preferences as to when or how sexual health would be brought into their child's life, right? So we wanted to really respect those preferences, but also we tailored our discussions to meet the developmental and educational and emotional needs of each patient. So no two patients were, exactly alike. But last but not least, we partnered with each other. Like, this was a brand new thing for us. So we had to check in with each other. We made sure that we were comfortable with the process and that we were all on the same page. This took a lot of preparation. So throughout that first year of 2023, we ended up educating 80% of our patients, ages 16 to 21. Some of them were late 21 people to transfer. So the results up here are of their initial knowledge assessment. So we didn't give in any information. This is just the results. Only 15% of the questions about male fertility were answered correctly, whereas a 93% percentage of the questions about female fertility were answered correctly. 68% of questions about genetics were answered correctly, but I know for a fact many of them said that they were just randomly guessing. So I feel like we have a lot of room in genetics. The good news is they did fairly well about the STI prevention. I mean, there's room for growth there. And I don't have the scores here, but every time our patients took a reassessment, all of the scores got higher. So, that was good for us. This is what I liked the most. We learned a lot about what mattered to our patients and where they got the information from. So 92% of them had already thought about having a family. 75% had already wondered if CF would affect their ability to have children. So this is all before we had ever brought it up, right? When we asked if they had ever looked for answers on their own, half of them said that they had, and only 25% or a quarter of them asked their family, versus 67% was, well, let's be real, it was like TikTok and social media. That's where they were looking. And then finally, 30% of our caregivers, unfortunately, had limited or inaccurate information about CF fertility-related issues. So essentially, it all reinforced that even though we had not been teaching this, it doesn't mean that our patients are not thinking about it and looking for answers. We also sent a survey to our young adult patients. It's a small group, but about half of them answered. And their responses basically told us that they're comfortable talking to at least one of us about SRH, that they are comfortable talking about it in general, and that we created a good space for them to do that, which is nice. Most of them strongly agreed that learning about fertility was important and learning about genetics was important. The most interesting thing for me is the most preferred way that they wanted to learn about fertility was from us, and very few chose their family. So at this point, we know that they want to know these things, and it's our responsibility to not only initiate the conversations, but really to do it sooner than later. So in 2024, we were ready to really start extending SRH education down to our 12-year-olds, so 12 and up, and then to hit all of our caregivers, because had really only been focused on patients up until that point. A few changes that we made to make that happen. We wanted our caregivers to get used to the idea that we may be meeting with their kids alone, like the 12 or 13 years. So we do a pre-visit planning call where we call the patient ahead of time and go over like what equipment do you need, or all those things. So we added this statement on there that says the team may meet with your child alone at some point during the visit. So every parent or caregiver, a 12-year-old, hears this in their PVP message. So it's never a surprise if we ask to meet with them alone. And also if there's resistance, then we know ahead of time and we can kind of address that. We had an education day with our very own Dr. Velez, and it was for our families, it was only on CF and fertility. And then we also created a protocol. This was before we knew there was one coming out, to set the standards of when and how we were going to educate patients and families, starting from diagnosis all the way up to the time that they transferred to adult care. A lot of these conversations can be hard to have. So there were a few things that made it helpful for us. Normalizing confidentiality, normalizing that these are routine part of CF care, and that we are totally comfortable having the conversations. We have these all the time. So to sort of express our confidence to reduce maybe some of that discomfort on the patient level. Offering examples of questions that other patients have. I've heard that this patient asked me this, or a lot of patients want to know about this. So giving examples rather than just saying, hey, do you have any questions? Because they're going to say no, so giving them more opportunities. It's also really important to not go to the next slide when I didn't mean to, sorry. It's also important to offer, to avoid making assumptions, right? Not everyone wants to be a parent. Avoiding making assumptions about sexual orientation or gender identity, and to use inclusive language in order to create a more welcoming and affirming environment. This has led to so many more conversations with people asking personal questions about their relationships or contraception or binding, and it's given us the chance to provide better care, better education, and appropriate referrals. And my favorite part is when we educate our younger adults. A few visits later, they bring in their significant others, and then we get the chance to educate them as well. So that's really, and then we say like whether we approve their relationship or not. Maybe that's just me. I don't know if other people do that. Finally, the family role in their child's education is so important. But how do we go about encouraging that? We decided, with a lot of help from our PFAC, on educating caregivers early. The earlier they have the information, the more informed they are to help their patients. And their kids. I've heard some parents say that it's not like they're going to tell their 4 or 5-year-old the definition of fertility, right? But when they talk to them, they can make adjustments. They can be more inclusive in their language when talking about ways to have a family. And that's helpful to them to have that information early. As a center, too, we can model ways to involve patients in their care that then they can transfer home. Our center does goal setting with patients starting at age 5 or 6. So we're really big on, involving our patients in their care. And a really big deal is we can emphasize you have to go to your primary care, those well checks to get that preventative education and all of the things that we are not able to do. Like that's a big focus for us. Since we started, we've made a lot of progress. I mean, it's been like 3 years. So the chart shows here the percentage of patients we've educated by age. Now, keep in mind in 2022, it was 0. So for our 16 to 21-year-olds, we went from educating 80% in 2023, 90 in 2024, and now every single one of our 16 to 20-year-olds is educated. For our 14 to 15-year-olds, we went from 0 in 2023, 60 in 2024, and now every single one of our 14 to 15-year-olds is educated. And then for our youngest patients, the 12 to 13-year-olds, which are a little bit more tricky, we educated less than 10% in 2024. We're almost at 30% now. However, I should point out that almost 100% of them have been prepared. We've introduced a topic to them so that they know it's coming. And then in terms of our caregivers, we've hit 100 out of 102 families that we've educated, and I'm pretty sure it'll be 100% by the end of the year. So we're really proud of that. So I'm going to hand that over to Myvi to talk about the rest.
Shorter than Abby. Good morning, everyone. I'm Ivy. I'm the nurse coordinator at our center. I'm going to share a little bit about how we implemented the changes and the lessons that we have learned. So some of the initial steps. So we have a lot of QI projects going that were not focused on this. So we formed a little subgroup and actually worked really well. We called it the ACT work group, that stands for Adult Care Transition, focused on adult transition readiness and also this SRH education that we were going to focus on. So we did research and literature review to get us up to speed with the latest recommendations. We developed educational handouts with the new education that we learned and wrote a standardized protocol that we were able to test with multiple PDSA cycles to figure out how to best do this in a busy clinic. With this, we collaborated with our PFAC parent partners also to get feedback about how they wanted this information and when they wanted this information. We developed the EMR smart phrase for documentation to keep track of this. And then it was also very timely. We were kind of in the thick of this work when we got the email about the position paper that came out. And we were able to kind of get some of that guidance and help add that to what we were already doing. So this is the SRH education protocol that we developed and tested. So in that diagnosis to 2-year-old, the kids are younger. I know that initial like the diagnosis visit, the first visit is very busy. So we don't very often do like that fertility education then, but sometime within the first 1 to 2 months. We give the SRH handout, we review the genetics with them, and then we loop in our genetic counseling partners to help with this education. We do this again at 5 years of age, giving the handout again to the parents. We know that the initial years are really hard. Some of them are first-time parents getting used to taking care of their kids with the additional complexities of caring for someone with CF. And so at 5, we do this again. And then we're careful not to really review it like with the patient there. So we don't want them to kind of know yet if the families are not ready, but we do give the handout to the parents just as a reminder, giving them a space to reach out to us if they have any additional questions. At the 10-year-old to 12-year-old mark, it becomes important to start preparing them that we're going to be meeting with the patient by themselves starting at 12 years of age. And I think this has been huge in changing the culture of a lot of the parents and the patients that are being seen. It prepares them, gives them time to kind of wrap their head around, not being there for the full visit. And I think it has really greatly decreased the resistance that we have felt. We get more resistance with those older kids that we started implementing this with initially. But I would say that now, we rarely get someone that refuses to allow us to meet with a child on their own. So 14 to 15, all the way to 21, we're giving these handouts annually, doing assessments and education with the patients in the room, at least for some part of the exam on their own. Starting with the older age group, about 15 years old, we started kind of tweaking the assessments a little bit to have like a multiple choice question test that they're able to kind of do during downtime. And it's been really well received. They're able to kind of go through and do it on their own time. We walk in with knowing where their deficits are and able to kind of like address that with them when we walk into the room. And then important to note, throughout this whole time, we are assessing and facilitating the PCP linkage piece, reinforcing the importance of having primary care while they're still, being cared for at our CF center, because they are really experts and they're going to be able to help us kind of guide them throughout this time. And so as a pediatric center, we're tasked with a unique situation where we're going to have to care and educate parents as well as the children. So we are giving early education to the parents at diagnosis. We're also then preparing both of them for this change in dynamic when the child is getting older and more independent with the clinic visits. So co-production with the parents is huge for preparing for these very sensitive discussions. So it's very important to utilize an individualized and respectful approach. So we have to think about different parenting styles, different personal preferences, cultural considerations, health beliefs, health literacy levels of some of the parents and patients, and also patients' developmental age. Sometimes we get like the parents will say, he's a young 15, and so we kind of really have to tailor that education to meet them where they are. And also important is that we have to prioritize this education for all people with CF. I know that, I'm sure people will refuse to have us be able to give this education to the child, but for us, it's important to be able to at some point. So we prioritize the right of the person with CF to have this education. And then I have an example about what we did with one parent that almost refused. In terms of preparing the team, so we had alluded earlier that we got ourselves up to speed with the education, doing the education day and all of that. And so this is a copy of example of the assessment that we did. These are the multiple choice questions that we added to our already established tool that our institution was using. And then the bottom is an example of what our blurb looks like inside. We use Cerner. So inside of the EMR tracking, when we would put the date it was done, the education, in the beginning of diagnosis, the age and stuff like that. So this is important to allow us to document, but also important to remind us when the next set of education is due. So for interventions, like the nitty-gritty logistics of getting this done in clinic, a lot of it happens during the clinic prep. So we're looking at the chart review, seeing when the patients are due for their initial and annual education. During the pre-visit planning, we have a team member calling the parents, preparing them that this is going to be the visit that we're going to meet with a child on their own. In the future, for our Spanish-speaking families, some of those, it's hard to educate them with the child in the room. So we're planning to use this time to educate the parent and then getting their feedback before we educate the patient. clinic cuddle becomes important because this is tracked, and then so we are able to determine who's going to focus on this and when they're going to do it. So this is the tool that we use. We have a live document dashboard in clinic. This not only marks where people are, who's seeing who, what still needs to be done, but in the red, we also mark when things like, the handout needs to go out, when are we doing the assessment, as a visual reminder that it needs to be done in clinic so that we ensure that it gets done. These are the examples of the education materials that we came up with. The highlights include CF genetics, pathways to parenthood, potential barriers, importance of the PCP, how to get more information. We have our contact info in there for anyone who wants to discuss with us prior to the clinic visit, STI protection, and contraceptives as well. So some patient stories. So the first patient that got one of our handouts, I should say the dad. So it was a 12-year-old male Pakistani patient. His parents were very private. They had some denial about the diagnosis. CPS was involved at some point. The dad, I remember, had a very, like the deer in the headlight looks. Once I reviewed to him, I said, did you know about CF fertility, potentially for your son, and stuff like that? And he just gave me the deer in the headlights look. And I just remember that this is why it's important to do this very early. And so it kind of drives home the fact that it's so important to do it when the patient is young so the parents have time to kind of process too. And we had an 18-year-old male with a mom resistant to allowing us to meet with the patient alone. I think she didn't give him enough credit to be able to kind of participate in his care. So we had to wait until he was 18 to do this, but we were able to kind of ask the mom to step outside. She kind of like went outside and just stood right there, but we were able to close the door and have like a good conversation with him. And he had really good questions. So I think for a lot of us with resistant parents, by the time 18, they're sometimes coming to visit alone and stuff. It was easier to kind of get him to provide this education. And then finally, we have a 20-year-old autistic male who needed just re-education with multiple different techniques. And I add this example just to add that we just need, different forms of education because people are learning, better with different techniques. And the challenge with this one is the parents also had a hard time wrapping their heads around it. So re-education for multiple years in a row is crucial. And then some of the big lessons we learned throughout our work is that rapport and collaboration with the caregiver is crucial. Prepping the family is key. Having private discussions with the parents ahead of time is very helpful. And it's important to acknowledge that they have their own preferences and practices when it comes to these conversations. Normalizing the topic is important. And that the conversations and education as a care provider is easier with culture changes as we get more confident and comfortable with the education that we're providing also. Some of the reflections from our care team members is that conversations were easier with patients who were above 18 years of age, have good health literacy, have caregivers who are already supportive transition readiness education. The majority of these patients were more comfortable with and preferred to have this conversation with the CF care team members versus going to their PCP, though we still emphasize that that is important. And that we have further room for other improvements later on for our center, learning more about having a process in place to who to refer for what regarding fertility, doing better education with potential puberty delays and things like that. One other big area of focus is education for patients and families who speak a language other than English. We have Spanish speakers, Russian speakers, and Chinese speakers that we need to find a way to be able to educate them better. And these are just some of our practical pearls. Communication is key. We need to find a tracking system when we're doing this education. Protocol is helpful for sustainability within a busy clinic. And then we need to identify and have a backup care team member to own this process when the primary person is not there. And then something small but very helpful is that pre-printed education materials increases the efficiency and decreases stress during a busy clinic session. And that is all. Thank you.
That concludes our speakers, but now we'll have some time for Q&A and some discussion. And so I know there's several questions in the app, and Kevin and I can go through those, but also feel free to come up to the mic and we can take some questions at the mic first.
Hiya. My question is for Dr. Velez-Leitner. I'm an adult pulmonary fellow from the UK. So whenever I discuss sperm retrieval in clinic with patients, they normally ask me back, is there anything that they can do to increase the success rate of viable sperm retrieved? And so is there anything that you would advise your patients on modifiable factors, either lifestyle or medication that they can do? Thanks.
Thank you. I think that's a great question and something I get really commonly. So I'll answer it in two parts. One is that, I think a lot of common sense lifestyle modifications happen here. So this is not the time to start smoking. I think if patients can stop smoking, and that includes vaping and marijuana use, any other substance use, that's all very helpful. A lot of my patients take fertility as the opportunity to start training for like a marathon or some, P90X. And I tell them that's actually not great. We don't want you to go through dramatic weight losses or weight swings. If you can adhere to just a normal, healthy, I love a Mediterranean type diet, if you can start to increase your physical activity, so you're hitting that like 3 to 4 times per week, getting your heart rate up on a consistent basis, that's all helpful. But we don't want you to go through bariatric surgery to suddenly drop 200 pounds. That's not helpful. Unless you want to delay your fertility by a couple of years, then great. I hearken it back a lot to the timing, right? So my worst nightmare is when patients show up in my clinic and they're like, we're actually doing the retrieval in 48 hours. So what can I do right now? The answer is like, get some sleep and hydrate. I don't know, like nothing. I do think that there is not a lot of data on highly effective modulator therapy, but I of the one study that I can really recall in terms of what patients are doing, of the handful of men that stayed on modulator therapy, they had no adverse outcomes and they had normal pregnancy outcomes. So we don't think that there's any kind of concern to the fetus if the male partner is on highly effective modulator therapy at the time of their retrieval. And that's a common question that I get as well.
This question's for Abby and Maeve. You guys may have commented on this and I just missed it, but after you did the education, did you guys do any kind of like post-education assessment, like follow up with the patients to see if like what you guys were working on was working with them? And if so, like what changes, if any, did you make after that?
Yeah, so in that first 2023 year, we handed out administered the CFRIs questionnaires. And then 2 or 3 clinic visits later, we would bring them in and do the same questionnaire and see what kind of progress they made. They made progress, but the biggest barrier to us is that knowledge assessment was not really up to date. It didn't include anything about modulators. It didn't include anything which we thought was important about the role of primary care. And it just didn't seem to be what was the most important to our patients. So the biggest change after doing that reassessment is making our own educational handout and then our own sort of assessment. It was really, that year was just catching up because we feel like we were so behind. We just really needed to make sure we didn't send any 21-year-olds off not knowing anything. So the biggest change was, yes, they improved their scores, but we didn't love the way we didn't love that tool, so we created our own tool to prioritize what they wanted.
Hello, I'm Amanda from Seattle Children's, and Abby was actually my mentor through the social work mentoring program. So good to see you here. Yeah. After going for the site visit, I brought back some of these concepts to our hospital, and while some are very successful, others have been a little bit of a challenge to get the whole team buy-in on. So my question is, did you come across that at all? And if so, what worked for you to get the team buy-in?
I think we just got really lucky. So we identified a core team working on this project. And so at that point, we already have 5 different care team members that were kind of owners of this project. So I think one of those is identifying those key team members that can take turns educating. So we have our wonderful nurse practitioners and our pulmonologists that will do this education. But if they're like focused on other priorities that day and it's due, I will come in and do that piece. And so I think having someone back up is important. And even if you can't like get a big group together, at least, someone, so if you're on vacation or something, someone can do that education, I think is huge to have.
Yeah. We do the clinic huddle, like Myvi mentioned, and our first of all, team is amazing, and I love all of them. So it's a great team, and we're really great at QI. But also, if we didn't have a clinic huddle where we discuss this is the patient that needs this assessment today, and like who's going to do it? Does this person prefer a female or a male, or what's the issue? Is this patient going to be admitted? So we're going to defer. If we didn't have that communication as a team, none of this. I feel like we would not have been able to do any of this. So having your team be on board is great.
Hi, Kathy from the University of Michigan. I have two separate, completely unrelated questions. First off, CF Rise, we are huge CF Rise people at Michigan, but I was curious if you had communicated with CF Rise the challenges or the things that you thought were missing in the sexual reproductive health modules to see if they were possibly willing to update them, because I know they've done updates to CFRD and some others.
Mm-hmm. We have one kind of hiccup in our hospital is that our hospital has created these transition readiness assessments that they want us to use for everyone across the hospital. And they're not CF specific. So we would be doing assessment readiness questionnaires or assessments, and then we would have to do CF Rise in addition. And so our decision was to just sort of combine it and modify the questionnaires on reproduction and fertility in our own hospital assessments. And so it just felt too much to do a CF Rise and then do our regular annual assessments. But no, we have not reached out to them about that specifically, but that's a good idea.
Thank you. My other question is just my brain doing too much. I saw a wonderful talk earlier, maybe yesterday, about smoke exposure with CFTR and the effects that it have on people with CF, but also on carriers. And I was just curious if there's any literature out there, if you all know anything about the impact of CFTR on infertility in general, and if that's I'm already like, I need to be sending more people to genetic counseling and all of that, but just curious if there's any information about that.
It's a really great question. I think that it's a complicated one, and we're still waiting on a lot of data to present and to mature. We think that, we know that the CFTR is present throughout the male genital tract. So from the hypothalamus to the pituitary down to the testicle and an individual sperm is in addition. We know that it can really change quality of sperm. Maybe it'll change quantity of sperm. And we're hopeful that as we get more data in the post-ETI era, that we'll start to be able to get better conversations and better informed discussions with our patients about what they can expect. But yeah, right now I think that time will tell.
Thank you.
Hi, I'm Dale Mazer. I'm also from the University of Michigan. I'm an adult general internist who's PACE awardee. PACE, for those who don't know it, is the Program for Adult Care Excellence. We've been tasked with providing primary care to adults with cystic fibrosis. So I've now been to multiple lectures during this conference at which I've heard that same statistic that people would rather talk to their CF team about things that seem very primary care-y to me than talk to their PCP about it. And I'm wondering if you have any feedback about that, about why that would be, because in my non-CF patients, I talk about sexual health and reproductive health and smoking cessation and not starting smoking, exercise, and all the stuff all day, every day. So I would love some feedback about that. I'm not that scary.
You don't seem scary. I think that's a really great question. I have perspective on it, and then I'm curious what the rest of the group thinks. My perspective comes from the pediatric side of things, and so it varies a little bit from your experience. I think that the frequency with which we see our patients with CF and the long-term relationships that we establish with them over the years on the pediatric side is probably one of the biggest drivers for them. Just having a relationship and feeling really open and honest and wanting to have those conversations. I think especially in an adolescent patient population who's maybe a little more hesitant to talk to someone that's not a peer about these issues. And so I think probably in peds, that is one of the reasons for that. I'm curious what the other panelists think about this, though.
I would agree with a lot of what Ellen had said. I think it's that a lot of the care that we deliver so emphasizes partnering with families and partnering with a person with CF. And I think that allows us to establish really effective relationships. And now our goal really would be for them to develop similar partnerships with their primary care providers. And we want them to find those relationships, but it's just, perhaps a little bit of a lag in where we're at with that right now as people with CF get healthier and we identify appropriate primary care providers for them to work with. Even in the latest iterations of the care team model that should show the importance of the primary care provider, I think hopefully we'll build those relationships so that they do use the primary care provider as another trusted care team member, and that we'll have relationships that can weigh in on the CF side of things, but that they'll also be able to get some of those primary care answers from the primary care provider.
I think I can add a little bit to that too, because I don't get the benefit of seeing these patients from birth or, for extended periods of time. I'm very much like I come in, we treat, there's a follow-up or two, and then I probably bow out. But I will say that I'm very lucky that I work really closely with the Rutgers CF team. And I think by the time patients they're reaching out to me to say, hey, they just want information on fertility. Hey, their testosterone is low. Can you see them? Patients are coming in saying, Dr. Jagpal is my CF doctor and she knows you well, and what can you tell me? So I think there's a lot of patient buy-in in that situation. And, I think I would really encourage you, find your community partners, find your specialty partners and make that relationship, because patients just feel so much more taken care of. And they feel safer, and then they walk into my office more confident in what I'm going to tell them, and they're less shocked.
Hello. So for our primary care focus, this project actually launched us into a whole new project of linking with primary care. So, and we have a poster on it too, but the main part we did is we sent letters to our PCPs explaining what we're going to cover, but also saying we know you're going to cover the basics and XYZ, and creating that relationship and that communication with them. Trying to increase linkage from with our patients with their PCPs. So I really think it's a partnership, and we're not expecting them to go over the CF related, fertility. We're letting them know, hey, we're going to assume that responsibility, but one, we want you to know about it, and two, let's partner together. And we've gotten really good responses back from PCPs. So it's just all kind of clumped together, because some of them aren't going, they're not getting, just like their regular checkups. So it's been a big part for us.
We'll use some questions from the app, and then I'll come right to you next. So we have 2 questions for Kevin in the app. I'll do one. Can you please clarify if combined oral contraceptives are contraindicated in advanced liver disease, but someone that may not yet be to the point of discussing liver transplant? And then is there concern for a patient on a combined oral contraception and a history of massive hemoptysis? So your thoughts on hemoptysis and significant liver disease.
So I would probably try and avoid the use of combined oral contraception for advanced liver disease, even if we're not yet at the point of transplant. I just think that there's a lot of risks associated with it, and knowing that you've got 2 hormones hepatically cleared with advanced liver disease, I think the risks probably outweigh benefits, although there's opportunities to have that discussion. In terms of massive hemoptysis, I don't have as many concerns related to that, with the caveat being depending on if we're utilizing any medications to perhaps stop that clot, stop the bleeding that could be clot promoting, I would be a little bit cautious about that particular interaction.
We can field your question.
I may not have it anymore. Luke from Dayton, Ohio. My question was to Kevin about the same topic, about just because we went through it so quickly. I have a lot of patients with CF hepatobiliary disease, and just the thought on using estrogens in those patients. Maybe OCPs, but also HRT and that kind of topic. I think you talked about it with the advanced liver disease, but it sounds like you'd be less concerned.
If we're just talking about elevated liver function tests, or like even maybe mild like presentation on the ultrasound, I don't have any concerns, no.
Thanks.
I'll ask another question to Kevin. Let's see. Okay. So some families with CF have been struggling with body image and weight gain in the post-ETI era. How would you address if a female with CF is concerned about taking both ETI and a combined oral contraceptive, especially if they're seeing a lot more weight gain than they would like following their ETI start?
Yeah, I think there are really two parts in my answer to this question. I think one is one of the things that I love most about the care for people with CF is our multidisciplinary team. So I think that's where, the interaction with the dietitian on the team and talking about maybe some strategies to address weight gain from that perspective. But then also I think in terms of the contraception piece, what are the main goals for that individual? And is there a particular reason we're doing combined oral contraception? Is that really, if weight gain is a concern for them, is that still the best option for them? Or have they thought about other methods that might be more appropriate? I think there's a lot of great opportunity for partnering in that scenario between a pharmacist, the clinician, the dietitian, and the person with CF to identify really what their goals are and how we can both meet their contraceptive needs while also being cognizant of their concerns related to weight gain.
There's a question about male infertility treatment, and someone asks, they say, I'm curious about the rates of successful procedures. It looks like various methods are about equally utilized, but are the rates of successful retrieval different?
So that's certainly one of our questions in our retrospective and hopefully prospective databases, is understanding which one is best. The way I look at it right now, and I think most of my colleagues look at it, is what do you have? So if I examine a patient and I say, look, you don't have an epididymis on either side, or you have one, but it's really tiny, I'm probably not going to try to poke it, because it's more likely they're going to have some morbidity from their procedure in the terms of pain or bleeding and swelling, versus making one controlled incision, going into the testicle and taking sperm out there. Even outside of the CF community, there's a lot of debate in urology about, is epididymal sperm better than testicular sperm? We don't really know. So I look at it as, okay, what do we have? And then the next question is, what do you want? So I have some patients that will say, I really don't want to go to the OR. Can you just do this in the office? I don't want to deal with being NPO and pre-op clearances. I don't want to deal with anesthesia. Let's just grind our teeth, do it in the office, and then be done. In which case, okay, let's do a quick testy and then we'll see what we get. And I have other patients who say, I literally never want to see you ever again. I want to do this once and then I want to be done. So we take them to the OR and we probably do a little bit more. But in terms of what is better, I don't have an answer yet. Ask me again in a few years.
All right. Our next question for Abby and Maeve. How do you navigate the families that are resistant to having their child be seen alone by the team for the discussions about sexual and reproductive health? And then also, like, how do you navigate the caregivers that don't want the team to approach their child about the topic?
I don't think we've had anyone that said absolutely not. But in the case of one of the patients, we ultimately had to wait until he was 18 and then just ask the mom to step out. Because at that point, he is able to have more of a voice. And I think that mom was, willing because she had to now at this point. But I do think nowadays that prepping them early just made such a huge difference. We rarely have anyone question the fact that, we're going to do this. It is really the standard of care. It's a change in the culture of our institution that helped, and also from us preparing people from an earlier age. That has been very helpful.
I think the whole the catching up part was hard because we had known these patients for 18 years, and it's like, ooh, all of a sudden we have to tell you this information. So that was challenging. But like Myvi said, as much prepping as possible. And then we've had a patient recently when we talked to the mom, and the mom said, he's not quite ready. So we said, well, how about we introduce the topic of genetics today, and then the next visit will go towards this. And so I think it's just working with them, and it's not going to be an option. We're going to educate them. But how can we do it in a partnership with you that's culturally respective, and whether it's with your religion or your whatever it is, like we want to be respectful, but also say that this is something that's very important. And if there were resistance, I think we just take the time to explore what that's about and better understand the family.
All right. We have one more question for you guys. Thank you so much for sharing your QI project on sexual and reproductive health education. Have you considered submitting your handouts to the CFF resource library? Or would you be willing to share?
Oh, of course. Yes, we will work on uploading it. Yes, of course.
All right. Are there any other burning questions? Well, I thank everyone again for their attention for this topic, and enjoy the rest of your conference.